let us begin with mood stabilizer. Okay, so if you talk about mood stabilizer, first thing is ki why we need to stabilize our mood. What is the reason for stabilizing our mood? So basically, and what are these drugs doing? How are they helping us? Or like, my point is this: how can they play such a very important role? Okay, so we have to know all these things. So over here, what we have to understand is that these mood stabilizers, they are psychiatric medications that help regulate the mood swings in individuals who have got mood disorders. Acha, can you name a disease where actually we get to see such kind of things called as mood disorder?
Mood disorder.
There is a very very famous disease. It is called as bipolar disorder.
Acha, bipolar disorder.
Yes, so bipolar disorder. Okay, now these drugs, they play a very very crucial role in stabilizing the mood, and they reduce the frequency and intensity of the manic and the depressive episode. Because what happens in bipolar disorder is that there are, like, those people who are bipolar, in simple language, there are moments when they are very very happy, and then there are moments when they are very very sad. Okay, and both have got no reason behind it. So if they are very very happy, again for that there is no reason. If they are very very sad, then again they have got no reason. So this is the idea, that sometimes they are very very happy, sometimes they are very very sad, and there are alternate episodes keep going on. There are like alternates. There are various types later on. I'm not going to getting into the psychiatry right now, but there are basic 2 to 3 types of bipolar disorders are present. Like one such disorder can be like type 1, and then there is another type that is called as type 2. So if we talk about this type 1, then over there we see that there are, like, in a particular day, there can be 50% of the day they are actually having some different mood, and rest 50% of the day they are having some other different mood. So again, 1 month they are good, and then another month they are bad. Okay, this is how the situation goes. This is how the situation works. So there are various kinds. Then if it is becoming more severe, then the person goes into depression. And once a person goes into depression, after that, like, that is a very dangerous phase if the person is going into depression, because the next phase that comes up, that is like they will have suicidal thoughts and they will commit suicide. So this is the idea. Okay. So this is what is mood disorder or bipolar disorder. Understood? All right. So if we talk about this mood disorder, like, they have got actually a wide range of conditions. Okay, so we'll primarily focus on the bipolar part, because mood, it starts with the mood swings and everything and all, but we'll focus primarily on the bipolar disorder. So bipolar disorder, if we go by the definition, so bipolar disorder is characterized by recurring episodes of mania or hypomania. You remember last class we had a discussion on those, what is a hypomania? And I told you that if the person is inappropriately happy, that is called as hypomania. Then the person will talk fast, walk fast. Okay, they very much happy, too much happy mood. Okay, so that is hypomania. So in bipolar disorder, the person will have episodes of mania or hypomania, okay, which involve elevated mood and increased energy, as well as episodes of depression with low mood and loss of interest. Okay, so this is the idea. Unipolar depression, on the other hand, involves only depressive episode. All right.
Yes, sir.
So effective management of bipolar disorder is very much necessary. Understood? Effective, because here we have to be very very careful, because these people have got suicidal tendencies. Understood? So over here, effective management of bipolar disorder is crucial more due to its chronic nature, and definitely mood stabilizers are like some god's gift over here. So this is a very very important group of drug present over here. So see, this is a very very basic idea the difference between bipolar 1 versus bipolar 2. So if you talk about bipolar type 1, so here at least one episode of extreme mania that lasting more than a week. But if it is bipolar 2, then there will be symptoms of hypomania. Okay, like that mania doesn't come up, it is a hypomania, and it lasts at least 4 days. And then when it comes up to depression, so the depression, it tends to be milder than the other bipolar types. And in case of bipolar 1, many a times there is no depression at all. But in bipolar 2, at least one depressive episode broken up by periods of hypomania. Okay, like
মানে alternate phase চলছে
alternate going on. Now in bipolar type 1, like I was telling you, that there will be high energy, the person talks fast, walks fast, there is euphoria. But in case of bipolar 2, there will be a feeling of hopelessness, fatigue, irritable, anxious, this kind of situation will come up in bipolar 2. So this is the basic difference between the bipolar 1 and bipolar 2. There are multiple factors, very like genetic factor is there, all these things we always connect to the genetic factor. But again, some other factor is neurotransmitter dysregulation. Okay, like if there is abnormality in the neurotransmitter, then also bipolar disorder can take place, like say dopamine. Manic episode mane the person is very very happy with high energy. That means what? Dopamine is elevated, high amount of dopamine takes place. So elevated dopamine level during manic episodes are associated with increased pleasure, energy, motivation. Again, if there is dysregulation of serotonin, then there can be depressive episodes, because serotonin is considered as the happy hormone, no? We discussed in the last class. So if there is dysregulation, then there can be depression also, depressive episode. Now if there is abnormality in the glutamate receptor, then again mood instability can come up. So there can be various of these neurotransmitters can create a problem. Then another thing is, there is something called as a HPA. What is HPA? HPA is a axis, HPA axis, hypothalamic pituitary adrenal axis. So the way I discussed about neurotransmitter dysregulation, similarly there can be a neuroendocrine system problem. So neuro as well as endocrine. So hypothalamo pituitary adrenal axis, if dysregulated, then that leads to altered stress response. Normal people respond to stress in a different way. These people will respond to stress in a different way. So there will be altered altered stress response. Understood? Then there can be abnormality in the regulation of sleep-wake cycle. Okay, if that happens, then also there can be mood cycling along with the sleep-wake cycle. Now there is a brain abnormality also, because neuroimaging studies have revealed that structural changes in the brains of individuals with bipolar disorder, say including the enlarged lateral and third ventricles, suggestive of brain volume changes, prefrontal cortex abnormalities. Prefrontal cortex is responsible for emotional regulation. So if there can be prefrontal cortex abnormalities. Amygdala and hippocampus, because amygdala is responsible for rage, anger, excessive happiness, so amygdala is for mood regulation, and hippocampus is responsible for conversion of short term memory to long term memory. So all these things, okay, there can be enlarged lateral and third ventricle, suggestive of brain volume changes, prefrontal cortex abnormalities implicated in emotional regulation, and amygdala and hippocampus involved in mood regulation and memory. Then another cause can be, it is called as neuroinflammation. Normally we know what is inflammation, but if you see there are inflammatory markers are at a very elevated level. Okay, increased level of inflammatory markers in individuals with bipolar disorder, and these neuroinflammation, this is called as neuroinflammation. So these neuroinflammation that contributes to the mood episodes and even cognitive impairment. Okay, so these are some internal factors. Now there can be external factors also, like environmental factors. Okay, so in environmental factors, most important is the stress, the stressful life events, especially during childhood, can increase the risk of developing bipolar disorder. Many a times when I personally speak to a lot of people related to these kind of condition, many a times I have to go to the childhood days. Many times I ask questions about childhood days, and many times people fail to understand that okay, Dr. Utsav, right now I'm stressed, right now I'm having so and so problem. So why are you asking me about childhood? Why are you asking me about my past? Because that time this problem was not there. My problem has started, 3 months back, 6 months back, 1 year back. But not like you're talking of the childhood, and that time I had no clue about this disease. So but the problem is this, that primarily the stressful events during this childhood, that increase the risk of developing bipolar disorder. So the childhood incidences, when we listen to the childhood incidences, it gives us a clear idea about maybe what kind of disease you are suffering from, what kind of conditions you are suffering from. Okay, then chronic stress may also trigger mood episodes in individuals with genetic
স্যার
predisposition. Huh.
বলছি যে আমার জল এসছে, আমি একবার নিয়ে আসি।
Huh, sure, sure. Okay.
ঠিক আছে।
Okay, so actually we are discussing the causative factors for the bipolar disorder. So here we are talking about this substance abuse. Okay, so substance abuse particularly stimulates, and alcohol can precipitate the mood episodes, or it can worsen the course of the disorder. Then comes up the neurodevelopmental factors. Like bipolar disorder may have neurodevelopmental origins with some abnormalities emerging during the early brain development. Then there can be imbalance in the neural network also. Okay, suppose there is any dysregulation in the balance between the neural networks that control emotion and cognitive processes, that can also lead to mood instability. Okay, then epigenetic modification. What is epigenetic modification? I hope you have heard of something called as DNA methylation, isn't it? DNA methylation and histone modifications. Now, this DNA methylation and histone modification can influence the gene expression, and this again contributes to the bipolar disorder. Then we have something called as neurocognitive impairments. So, cognitive deficits are common in bipolar disorder, and this may be related to structural brain changes and neurotransmitter imbalances. Plus, the pharmacological and psychotherapeutic treatments for bipolar disorder often target the neurobiological aspects of the disorder, including regulation of neurotransmitters and neural circuits. So all these factors, they contribute in this disease. Okay, all these factors. So we need to know that this was a brief discussion about the disease. So once we have discussed about the disease itself, now we can actually start understanding about the drugs, and let's see what are the mood stabilizers which exist. So a very very dangerous kind of a drug, if we talk about the classes, then we have got something called as anticonvulsants. Okay, like convulsion, suddenly one person is suppose sitting normally, suddenly the person starts shaking, then the person develops some frothy appearance from the mouth. Okay, the person's body starts becoming stiff. Okay, so that is convulsion. Suddenly convulsions take place. So any drug which helps to treat those phases of convulsion. Understood what is convulsion? Like sometimes we see such convulsions in case of epilepsy, fits.
Yes, sir.
Huh. So to treat those conditions, we use this category of drug called as anticonvulsants. Now, a very very promising drug for anticonvulsant is lithium. Okay, lithium is like a very old drug. It is used since early 19th century. Okay, it's one among the most potent mood stabilizer. And over here, one problem of lithium is that it has a very very narrow therapeutic window. So regularly the blood level monitoring is very much necessary. So it is used for treatment of acute manic and depressive episodes in the bipolar disorder. Similar, one more drug is there. See, if you learn these drugs properly, then they will be helpful for you in reading epilepsy also, because the same drugs are used for the treatment of epilepsy. So, if we talk about the valproic acid, valproate, I think we discussed valproate when we were discussing epilepsy. So, it is also an anticonvulsant, and not only that, it is also used as a mood stabilizer. Okay, and how does it work? It involves the GABAergic and the glutaminergic pathway, and it is used in treatment, once again, acute mania and bipolar maintenance therapy. Okay, so valproic acid is primarily used for maintenance therapy in case of bipolar disorder. Then there is another common drug, that is carbamazepine. Have you heard of this drug, carbamazepine? It's very common. It's also anticonvulsant, but again it has a mood stabilizer effect. So what does it do? It inhibits the voltage gated sodium channel. So once again we can use it here as well. Then we have got lamotrigine. Okay, so lamotrigine is an anticonvulsant and it stabilizes mood by inhibiting the glutamate release. But remember, unlike some other mood stabilizers, it is particularly effective in preventing depressive episode. Okay, so lamotrigine is a specialist in that part. It prevents the depressive episode. But the problem is, once again, it requires a slow titration. Otherwise, there can be severe rashes on the body. Okay, so to minimize the risk of severe rash, very slow titration is necessary. So these are all anticonvulsant drugs. Then we have got something like atypical antipsychotics, which can be used over here also. That is, we can have got aripiprazole. So aripiprazole alone is not used. You have to use it with some other drug. You have to use it with some other mood stabilizer, because it's a dopamine partial agonist. Okay, so it's a partial agonist at dopamine, and not only that, even partial agonist to the serotonin receptors. And as you can see, there is another drug. Now this is a very very interesting drug, that is olanzapine. Okay, I don't know whether we have discussed olanzapine earlier or not, because olanzapine is not only an antipsychotic, it is an anti-anxiety, it is an antidepressant, it is an anti-maniac, and it is used for treatment of obsessive compulsive disorder, etc. Remember this, olanzapine is a very very strong drug. Okay, like not strong drug, I should say, it is a very very good drug. Okay, so like we had studied na atypical antipsychotics, there was clozapine was there. If you remember, olanzapine was there in atypical, risperidone, so aripiprazole was there. So similarly here also, those we are re-discussing those drugs. So clozapine we are not discussing, but olanzapine is a very very good drug. Okay, it has anti-maniac property, antidepressant property, anti-anxiety property, antipsychotic property, and also the other treatments like OCD and all. But remember one thing, all these drugs, they take few weeks to start action. So it's not like you start the drug today and today only you will get action. These drugs will definitely take few weeks to come into action. So it can happen that you observe side effects first. Not therapeutic effect will come up later. Side effects will start coming up before, because side effects will not take so much time. Na? Therapeutic effect will take that time. So we have to always keep this in mind. Okay, so olanzapine is primarily used for bipolar maintenance, just like over there we were using what, valproic acid, and it blocks multiple receptors, once again dopamine and serotonin, and also olanzapine has got sedative effect. Then we have got another drug, quetiapine. So quetiapine is used in bipolar treatment, effective for both manic and depressive episode. Once again, wide receptor binding profile, again dopamine serotonin. See, all of them, they are targeting that dopamine and serotonin. So do you remember what is the funda here? Typical was only dopamine. If it is atypical, then dopamine and serotonin.
Hmm.
This was the basic difference in the antipsychotic category. Huh?
Hmm.
Okay.
Yes, sir.
Hmm. Next, then we have got another drug, that is topiramate. So if we talk about topiramate, it is also anticonvulsant, and what does it do is it blocks the voltage gated sodium channel. So if voltage gated sodium channels are blocked, then depolarization will not take place. GABAergic activity will increase. So the cells are going to go depressed. And then there is another drug called as gabapentin. Now gabapentin is used for seizures and neuropathic pain. Okay, but it also acts as a mood stabilizer. So I hope everybody understood these category drugs.
Yes, sir.
Okay. Huh. Now let us talk about a little bit of the very very special, the lithium. So this is what I was telling, that lithium, it dates back to 19th century, and lithium was more of having a calming effect, that is sedative. If you know, nowadays we use that word sedative. Now in it affects the intracellular signaling, but what you have to understand is, as far as the pharmacokinetics is concerned, it has got a short half life. That means it will get eliminated very easily. So in a particular day, you have to give multiple doses, multiple frequency, I mean frequent doses has to be provided, है ना? But again the problem is the therapeutic window is narrow. Now you have to give it frequently also, plus you have to check that it doesn't create a problem with the therapeutic window. So you have to constantly go for the monitoring as well. Okay, because see, lithium is very very effective in treating acute manic and depressive episodes. Okay, so how do you do the dosage? Of course, based on the blood level, patient's response, about the side effects. Acha, if we talk about side effects, what are the side effects that can happen? So number one side effect will be tremor. Okay, there will be tremors on the hand, shakiness. Okay, shivering. So that is tremor. Then there can be polyuria. Okay, polyuria means frequent urination, weight gain, and even hypothyroidism. And remember, lithium toxicity can lead to serious adverse effects like renal dysfunction as well as thyroid dysfunction. Okay, so not like anytime you feel like and you start taking lithium, no, you cannot do that. And then we have got the therapeutic uses, so there is no point in discussing. Now as far as the dosage and monitoring is concerned, so I think I discussed it. Then side effects, so again, the side effects we have discussed. Lithium interacts with various drugs, and during that time we have to adjust the doses. Okay, you have to keep this in mind. So you have got a clear idea about the lithium.
Yes, sir.
Okay, so moving on. So let's talk about those anticonvulsants now. So valproic acid. So mainly the same points will come up again that I was telling you, that it involves the GABAergic and the glutaminergic pathway. Carbamazepine inhibits voltage gated ion sodium channel, and lamotrigine specializing for depressive episode, and to prevent severe rash, we have to go with the we have to dose it very very slowly, the titration of dose. Now if we talk about the antipsychotics, then I think we had a discussion about aripiprazole, olanzapine, okay, and then quetiapine. So there's nothing more in it. We have discussed these points, na? So I'm not spending more time in it.
Hmm.
Yes.
And then, this is something which you have to remember, that if the lady is pregnant, okay, bipolar disorder during pregnancy requires a careful consideration of risks and benefits. We have to check which mood stabilizers are safe during pregnancy, and not only that, during breastfeeding, because not all the drugs are safe during this time. Plus, two extreme conditions: the kids, babies, newborn, and the old people. So, pediatric and geriatric population will require special consideration and caution. Okay, so that is why you always have to remember that regular blood monitoring crucial, very crucial for primarily for drugs like lithium and valproate. Okay, the monitoring and adherence is very important. It ensures patients are within the therapeutic range and minimizes toxicity risks. Now, as far as patient education is concerned, patients must understand that their medications side effects are and okay, and the importance of adherence to the treatment, okay, is very essential. Okay, these are few things that patients should be educated about. And if the patient is non-adherent to whatever the instructions that you are giving, whatever consultations you are giving, then that will lead to relapse, and that can also worsen the disease. Okay, so you have to make sure that your patients are going to comply with you. All the patients are under your confidence, so you have to make sure of that. Okay.
Yes, sir.
All right. So, moving on. Next thing that we'll talk about, that is the opioids. So, as far as the opioids are concerned, so let's talk about like opioids are obtained from a plant. Okay, what is the name of the plant from which the opioids are obtained? Opioid is a chemical that Bengalis love a lot, isn't it? We all take this drug, right?
স্যার পপি থেকে হয় মানে
Yes.
পপি
So here in Bengal it is called as posto. If you are taking it in a abusive dose, then it is afim. Okay, so opioid medications, they are derived from the poppy plant, and very old. It dates back to centuries and centuries ahead. Since centuries it is being used because it has a potent analgesic property. So if we talk about how they work, so opioids are class of drug that act on the opioid receptor, primarily found in central nervous system, but they are also present in the GIT, gastric system. Okay, so they are specifically known for pain relieving properties, and we have got both natural as well as synthetic compounds in that. Like if you come across the word morphine, I think you have heard it sometime, morphine. So if you come across the word morphine actually comes up from the I don't know, maybe Greek god Morpheus. Morpheus is the god of dreams. Now I don't know whether I think it is Greek only. I don't know, maybe it can be Latin also. I don't remember its origin, but the meaning of morphine is, it comes up from the Greek, like that word Morpheus, where there's a god of dreams. So when a person takes morphine, the person goes into the dreamy state, and that's how the name comes up. And nowadays, people buy a lot of synthetic opioids as well. A very common drug name is oxycodone. Now, how do they work? Okay, how are these opioids they are working? So always remember that do you remember in the previous classes we discussed about something called as the G protein coupled receptor?
Yes.
Yes. So basically opioid receptors are a part of G protein coupled receptor only, and they have got sub few families, receptor family, like there is a mu, delta, and kappa. Now activation of the mu receptor is primarily responsible for the analgesic effect of opioids. Okay, so how many are there? Mu, delta, kappa. So delta and kappa is not so important, but mu is very important. Okay, now remember that as far as the opioids, are you understanding what I'm saying?
হ্যাঁ স্যার
Okay, so as far as the opioids are concerned, there are two types of opioids. Okay, one is called as the endogenous opioid, mane the drugs, sorry, the hormones, the chemicals that are present in your body, and they bind to the same receptor, opioid receptor. So do you know some names of endogenous opioids? Endogenous means inside your body. No?
স্যার আর একবার বলবেন?
Names of endogenous opioids. Don't know, right? So, okay, I'll tell you. See, as far as the endogenous opioids are concerned, so have you heard of something called as enkephalin?
না স্যার।
না স্যার।
Acha. Have you heard of something called as endorphins?
আচ্ছা এন্ডরফিনটা
So endorphin, enkephalin, this kind of these enkephalin is very common. So chalo anyway these kinds of hormones, they are basically considered as endogenous opioid receptors. What is the meaning of endogenous and what is its opposite?
স্যার এক্সোজেনাস।
Okay, and meaning?
হ্যাঁ স্যার।
Matlab, mane, meaning?
স্যার আউটসাইড আর কি, মানে আউটসাইড থেকে এফেক্ট হবে।
হ্যাঁ. So if it is from outside source, then it is exogenous. If it is from within, then it is endogenous. Okay?
হ্যাঁ স্যার।
See, actually what happens, let me tell you. First you need to understand how the pain perception comes up. So suppose this is let's say this is your finger. I don't know how to draw finger. So let's suppose this is finger and okay, so this is finger and from here let's say one neuron is coming up and this neuron goes to the dorsal root ganglia and then this is going to enter where? Do you recognize this person? No?
হ্যাঁ পাচ্ছি।
Thank God. So this is entering the dorsal root ganglion. Now in this dorsal root ganglion, this fiber which is carrying the information, this is called as the primary fiber, primary sensory fiber, and from this primary sensory it goes to secondary. Okay, it is going to the higher centers. So basically what happens is, suppose this stimulus is noxious. Okay, let's say there is a pin going. Acha, maybe I have drawn an arrow. Acha, chalo, let's say arrow. Suppose there is a arrow because I don't know how to draw pin. So let's say somebody targeted an arrow to puncture your finger. So what happens is that the primary sensory neuron, they will give it to the second order in the dorsal horn. Now from there it is going to move upward to the higher centers. What is it called? Where will it go? It will go from the spinal cord directly to the which area? To the thalamus. And the thalamus will relate to the cortex. You remember or you forgot?
হ্যাঁ স্যার একটু একটু মনে পড়ছে।
Ektu. Okay, so remember this, that this fiber will go from here and enter the thalamus. So what is the name of this fiber? Spinal cord to the spinothalamic tract. Okay.
Yes, sir.
Alright, so it will go to the spinothalamic tract, and from there it is going to finally go to the somatosensory part of the cortex. So here this is going to go to the oops. So it is going to go to the thalamus. It's going to go to the thalamus. I hope you remember what is the job of thalamus. Do you know what is job of thalamus? Any idea?
So ওটা ঠিক মনে পড়ছে না, বেস অফ দ্য ব্রেনের ওখানে থাকে, ওটা মনে আছে।
Acha. Rest of the people?
মনে পড়ছে না।
Actually, thalamus is known as the relay center of your brain.
ও ও
হ্যাঁ স্যার, স্যার সেন্সরি ইনফরমেশন গুলো এখান দিয়ে পাস করতে হবে, মাস্ট
Acha.
হ্যাঁ স্যার।
So, what do you mean by relay center of the brain?
স্যার সব সব ইনফরমেশন যেগুলো আউটসাইড থেকে গ্যাদার হচ্ছে, মানে গ্যাদার করছে, মানে সেন্সরি নিউরনস ওখান দিয়ে পাস হবে বিফোর গোইং টু দ্য কর্টেক্স।
So, what is the benefit? All the information has to pass through the thalamus.
অ্যাসোসিয়েশন হতে পারে, মানে সুবিধা হচ্ছে, লাইক সবকটা ইনফরমেশন এক জায়গায় থাকছে।
সবকটা information in one tiny spot.
এক জায়গা দিয়ে পাস করছে, তো সেটা বলছি।
So I am asking what is the benefit? Pass করবে তো fine, I understood, but what is the benefit? That is the normal neurons are also, transferring information. So what is so special about thalamus?
স্যার ওই অ্যাসোসিয়েশন কিছু, মানে একটা সেন্সের সঙ্গে আরেকটা সেন্সের ওরকম অ্যাসোসিয়েশন।
Association, so like you have to tell which association, because we have got a lot of association. We have got association for speech, we have got association for memory, we have got association for so many things. So you have to tell, if it is association, then you have to tell which association. Do you know?
না স্যার।
No. Okay. So, see, actually, if I talk about thalamus, you don't know the function of thalamus. Thalamus is, you have to know, thalamus is very, very important. Imagine that, suppose I am taking a class in a classroom. Say there is a lecture going on in your LT. Okay, in your lecture theatre, there is a lecture going on. So, if there is a lecture going on, and suppose you have got two friends who are talking to each other at the back seat. It happens. This is, I'm telling you, I think, a very, very common scenario.
হ্যাঁ স্যার।
So, you tell me now that who is speaking at a higher voice? Is it the teacher or is it those friends?
স্যার টিচার অফ কোর্স।
Teacher, of course. But you will see that means if teacher is talking at a very, very high pitched voice, but still the two friends are talking to each other and they have no clue what is going on in the class. But as far as science is concerned, a better stimulus, a stronger stimulus is actually provided by the teacher only. So, how is it that the friends are not listening to the teachers and they are only listening to each other? Because thalamus, when we say it is relay center, so it is, don't think that it is just allowing things to pass through it. It actually filters everything. It knows what to pass and what not to pass. Imagine if you are sleeping and outside there is a huge traffic. Okay, maybe your house is beside some busy street, so there is a huge traffic. So, like over there, if you see that there is if you are trying to sleep, so what do you think? there will be that traffic will not allow you to sleep, or you will be able to sleep.
স্যার ঘুমোতে পারবো, এইবার বুঝেছি ম্যাক্সিমাম মানে ইগনোর, কিছু ইগনোর করছে, কিছু যেতে দিচ্ছে, লাইক
হ্যাঁ,
গেট ওয়ে টাইপ অফ।
yes. So this is the thing. So always remember that these thalamus, they actually tell you, like they actually decide what you should listen and what you should not listen. That's the job of the thalamus. Understood?
স্যার হ্যাঁ স্যার বলছি ফ্যানের আওয়াজটাও তো একটা ওরকম টাইপের।
হ্যাঁ, definitely, definitely.
স্যার ফ্যান অন মানে অনেক সময় দেখবেন শীতকালে যখন ফ্যান অফ হয়ে যায় তখন কিন্তু মনে হয় যে ফ্যান অফ হয়ে গেছে, তখন মানে তখন ব্যাপারটা বুঝতে, তখন তো থ্যালামাস তো মোস্ট অফ টাইম ইগনোর করে আসছে
হ্যাঁ।
তাহলে তখন মনে হবে মানে
তো-
ফ্যান চলছে না তখন একটা ইয়ে হয় না স্যার।
হ্যাঁ, তো no, that is because of so many other sensations, like maybe you are feeling hot, or maybe there is a change in something, like some change has occurred. What change? Maybe there was some sound which was there which you were ignorant about, but that sound has started.
হ্যাঁ স্যার ওটাই বলছি, কানে রিং করে মানে
Yeah,
like
so that is something, some different thing has happened. That is the reason.
ওকে স্যার।
Okay.
প্রথম এক সপ্তাহ লাইক কানে রিং করছে যেন পাহাড়া চলছে
হ্যাঁ।
হয়ে যায়।
একদম clear.
হ্যাঁ স্যার।
Okay, so always remember this, that this is the job of the thalamus. So once the information reaches the thalamus, now from this thalamus there will be, again they will be all relayed to the, actually on the opposite side, but so I'm showing it over here only. So it will be going to the cortex, and then your cortex will be actually understanding what is going on. So this is how your pain is perceived. Now what happens is, when we talk about this neurotransmission, so what are the neurotransmitters used here? There are a few specific kinds of neurotransmitters used. So number one neurotransmitter which is very very active, that is called as glutamate. Okay, glutamic acid. So glutamic acid is one strong neurotransmitter. Then we have got something called as CGRP. Okay, then we have got something called as substance P. This SP is not superintendent of police, it is substance P. Okay, and glutamic acid is more common, because if you remember the receptors, glutamic acid actually works both on NMDA receptor as well as AMPA receptor, both these receptor, and it also excites the second order in the dorsal root. The second order neuron are mainly excited by this glutamic acid. So glutamate is very very common. Now this these opioids, they bind to the opioid receptors, leading to decreased release of substance P and all those neurotransmitters. And if you reduce the neurotransmission, then pain transmission is reduced. Understood?
হ্যাঁ স্যার।
But the problem is that last class, or I think class to last class, I don't remember, we discussed about mesolimbic pathway. So from the midbrain to the limbic system, the mesolimbic pathway. So there is activation of the mesolimbic pathway, and that leads to euphoria and reward. So now you understand why people actually do drugs with opium, because it will, number one though is it is reducing the pain sensation, number two is it is putting you in euphoria. So don't you think it's a better effect, very good effect?
হ্যাঁ মানে কি
হ্যাঁ।
বলবো, ইউফোরিয়া ইটস লাইক মানে তখনকার জন্য খুব ভালো একটা এফেক্ট।
হ্যাঁ, so that is why this is so interesting. Now as far as the kinetics are concerned, we can give this drug either enteral route or parenteral route. Mane you can go orally, you can go IV, you can go IM, you can go transdermally. Okay, and if you are going by the enteral route, I hope you understand that there will be first pass metabolism or metabolism by the liver. Hepatic metabolism will take place definitely. Now opioids have different half lives. Okay, like sometimes they last for, their half lives are minutes to hours. Say there is a drug called as fentanyl. Have you heard of this word drug, fentanyl? No.
না স্যার।
এটা আমি মনে হচ্ছে শোনা শোনা কিন্তু
The
মানে
fentanyl has got a half-life of few minutes to days. But if we talk about methadone, then like its half-life is few days. Okay, sorry, I think I said fentanyl minutes to days. Sorry, minutes to hours I meant. So for fentanyl, the half-life is minutes to hours. But as far as methadone is concerned, its half-life is days. Plus, there is always the topic of cross tolerance you have to remember, because chronic opioid use can lead to cross tolerance. So if there is cross tolerance, then your dosage will increase or decrease or remain same.
টলারেন্সটা তো ডিক্রিজ করছে।
So if it is having more tolerance, if it is having lot of cross tolerance, then you have to give more dose, na? Body is
হ্যাঁ
tolerating it, so you have to increase the doses in that case. So how do we, or why do we use these opioids? So talking about the therapeutic uses, first thing is acute pain management. Okay, because many a times we also have to give it. Suppose you do a extraction, you do some impaction, you do any kind of surgery. After that, you have given normal painkillers and everything, but at night patient calls you up, says that no, it is unbearable pain, I cannot get rid of this pain. Or maybe there is a trauma. So what to do? You can use the opioid painkillers. Okay, because acute pain can be managed, any reason, be it post-surgical pain, trauma, whatever. You have to know nothing about the cause, because this drug works at your brain level, na, CNS level. So what is the point of knowing what happened in the PNS level? Like, you can know for your curiosity purpose, but for drug you don't need. Okay. Plus, sometimes palliative care is also given, primarily morphine. Okay, palliative care, you understand? Just symptomatic relief. Okay.
হ্যাঁ স্যার।
Okay. Now you should be very much familiar with one word that is called as OAMT. What is OAMT? It is called as opioid agonist maintenance therapy. Now here, which are the drugs that we use? You remember I told you that long half-life wala methadone, and then there is methadone I have written already. So what is the point of writing again? I think I should write some names which you will be hearing first time. So let me write one more name. That is called as buprenorphine. Like, we have got morphine, and this one is
স্যার
huh
বলছি এরকম কিছু ন্যাচারালি মানে ইউফোরিয়া কজ হতে পারে। মানে আমার স্কুলেই আর কি এরকম একজন এক্সাম্পল ছিল আর কি, সে প্রায় নিজে চিন্তা করতো যে ওর বাবা মা ছেড়ে চলে গেছে, অ্যান্ড ওই ইয়েটা দিয়ে ওর একটা মানে কান্না আসতো, কাঁদতো, অ্যান্ড হি ওয়াজ ভেরি অ্যাডিক্টেড টু ইট।
no, I don't think that. Again, depends on the age.
এজ খুব একটা বেশি নয়, ওই তখন 15-16 বয়স ছিল।
No, that is fine. So that is a time of development. So at that time this can happen, but we have to make sure that this doesn't last long.
তো মানে পুরো একদম নাকি অ্যাডিকশন হয়ে গেছিল। আমি বলছি অ্যাডিকশন ন্যাচারাল, ওই ডোপামিন মানে
হ্যাঁ,
নিজের
definitely.
হয়।
হ্যাঁ, হয়তো, definitely. Okay, so methadone and buprenorphine are used for this opioid agonist maintenance therapy, and now we have to talk about some side effects. So what are the side effects? So the first side effect that we should talk about, that is about constipation, nausea, sedation, and very very dangerous respiratory depression. So these are the common side effects. Constipation is common, nausea is common, sedation is common, and respiratory depression is also common. And another thing about the side effect is that there can be tolerance. Okay, tolerance can develop to some of the side effects, but not respiratory depression. Now there is something called as opioid use disorder that happens only when you are taking prolonged opioid. Okay, so it has got a abbreviation as OUD only, opioid use disorder. Now high doses of opioids, if combined with other depressant, say benzodiazepine, so that can lead to respiratory depression and overdose also. Okay, many people, like recently there was a thing came up that one kid took some blood pressure medication and committed suicide by taking those pills. So remember, like, these drugs also are not given without prescription. These drugs are not OTC drugs, they are not available over the counter. Why? Because this can, if there is overdose, this can lead to respiratory depression. And another thing that you should be bothered about, that is called as the withdrawal. Okay, because once you are discontinuing the opioids, withdrawal symptoms will come up. What are withdrawal symptoms? They include anxiety, restlessness, okay, flu-like symptoms, all these things. Clear?
Yes, sir.
All right. Now, this is the story of opioid, and opioids are powerful analgesic agents, and but they have got complex pharmacology, and we have discussed what mechanism of action we have discussed. We have discussed pharmacokinetics. We have discussed uses. I don't think we have left anything. So, fine. That's it. That's all about the opiate analgesic. Okay.